Let's talk terminal dentition. So first and foremost, I want to remind everyone that we still have 3 spots left for our master class on porcelain veneers, which will be held in Atlanta, Georgia this year, September 15 and 16. September 16 is sold out. September 15, again, we have 3 spots available. That's a Friday. So if you want to be part of this hands-on experience, it's a whole day activity. Make sure that you email us at the end, or you can visit our webpage, www.romerodentalseminars.com, and just click on the Learn More button, and you will be able to register directly through our webpage. We do have 9 CE credits that will be provided throughout this course. Again, if you want more information, this is how you go to the information. You visit our webpage, you hit on the Atlanta September 2023 seminar under the seminars link, and you will be able to get all the information you need to register to our course. We also want to thank our sponsors, Colteen, Oral Arts Dental Laboratories, and Romero Dental Seminars for helping us provide this 1 CE credit through this presentation. And I will show you immediately how you can achieve that 1 CE credit. Once we are done with our webinar, all you need to do is visit our webpage, www.romerodentalseminars.com, click on the link Webinars, and then click on the link CE Quizzes. You will find a CE quiz, called Terminal Dentition. Just open it, download it to your computer, answer the 5 questions, complete the information below, your name, your age, membership number, and the date, signed, and email it back to us at romerodentalseminars@gmail.com. And remember that we have over 95 videos uploaded in our YouTube channel. So every webinar that we have, that we've been giving for the past 3 years, that have been recorded, are uploaded, and they are kept in our YouTube channel, and you can access them for free. So make sure that you visit our YouTube channel, subscribe to our channel, and also share our channel with other colleagues so they can also benefit from this information. So for today, our learning objectives are very easy, very simple. After viewing this webinar, the participants should be able to follow the remaining teeth assessment algorithm, identify the contributing reasons why you would keep teeth, and understand how to apply the algorithm clinically. So let's talk about considerations for terminal dentition. And again, today there's so many cases that fall into this group. And for either young or even more experienced dentists, sometimes, when we have a conservative mentality, sometimes it's really hard for us to decide whether to keep or extract teeth. And we feel like, and we know that by removing many, multiple or all teeth in our patient's mouth, we are really, if we don't restore them back to function, and even if we restore them back to function, we will never be able to restore them back to 100% masticatory efficiency. So that's the reason why this is such a complicated topic. And as you know, today there's many dental practices out there that strictly promote this type of dentistry. All they do is extract teeth, edentulate patients, place implants, and restore them either with removable prosthodontics or with fixed prosthodontics. So this is a common practice today in dentistry. And what I want to try to do with my presentation today is try to guide you, share with you some information, some evidence out there, and try to guide your decision-making tree using an algorithm, using a good clinical analysis of every different clinical situation will help you understand when keeping some of these teeth it makes a lot of sense. When would I decide keeping versus extracting? Would the financial or economic problems with the patient, would those affect my decision making? All these things, we have to put them into account as clinicians in order for us to make the best decision possible. So when it comes down to terminal dentition, I like to refer to this is a publication in a web page. So this is not an article, not yet at least, but I know that Dr. Mitrani has published numerous articles in regards to terminal dentition. And this information is actually one that was shared by him in multiple of his presentations and lectures. And what I like about it is that it helps me simplify my thought process. And I like lecturing, I like teaching young dentists. I've been a program director before. So when I was working with younger dentists, I wanted to help them understand, navigate this decision making through an algorithm, because it would make it a lot easier for them to support their cases. At the end of the day, we as dentists, any decision or any treatment plan that we offer to our patients, we have to make sure that we can support them by evidence. And most importantly, that our decisions are really in the best interest of our patients. Because again, many of them are just trusting 100% what we are saying, what we are presenting. They're not questioning our decision making. So we have to make sure that our decision making is solid, is strong, and most importantly, is based on evidence. And so one of the things that I like about this terminal dentition article written by Dr. Mitrani in 2019 is that the question that he had for this article was, where do we draw the line? Where do we decide, yes, this patient is a candidate for a full mouth extraction, or no, I'm going to save some teeth, some strategically positioned teeth so that I can go ahead and use them in my restorative means for this particular case. So there's two undisputable reasons for full arch extractions, and there is no questions asked. There's no discussion here when we're talking about these two reasons. Obviously, the number one is advanced structural damage. As you can see on the left-hand photos, all the photos that I'm sharing with you today are my patients. These are my clinical patients, and I have used this same philosophy, this same treatment modality, this same algorithm to make these decisions. When you look at my patient on the left-hand side, you can see that the structural damage on the majority, if not all of her teeth, are very they're very aggressive. So there's very little that I can do for this patient to try to save their teeth. The teeth are not positioned adequately. The ones that I could probably quote unquote save, they're not in the best position possible. And if I'm able to save any teeth, it's probably going to be 2 or 3 teeth. So the number of teeth that I will be able to save for this patient, if I consider structural damage, there would be so little teeth remaining that most likely I'm not going to be able to use them in order for me to restore this case to success. Now, the other thing that I want to tell you is that you also have to consider the age of your patient, right? The patient on the left-hand side is probably like 25 to 27-year-old female patient. So again, if you look at this case, I know that this patient is going to have 60, 80, at least 60 more years of life, maybe. Or let's say that she lives till 70, she would have, 50, 45 to 50 more years of life. So I have to understand that, okay, if in this short period of time, she hasn't been able to maintain her teeth healthy, what would change? Would it be easy for me to change anything within her environment in order for her to keep, whatever number of teeth I'll be able to save? So those are things that you also have to think about, because it's not the same when you have a 90-year-old patient and you're trying to save one tooth compared to a 25-year-old patient where you're trying to save one tooth. It is not the same clinical situation. So that's something that you definitely have to consider. And the second reason would be advanced periodontal damage. When you have advanced periodontal damage, you have, suppuration, you have mobility, attachment loss, probing depth greater than 10 millimeters, bleeding upon probing. There's just so many things going on there that saving those teeth is also a challenge. In the case that you see on the right-hand side, we were actually trying to save, this patient was adamant that he would not want to lose his teeth. He wanted just to replace the missing, the fracture lateral incisor that you're seeing there. He wanted a partial on the upper, and some of his teeth were nice and stable, meaning that they were not mobile. But this patient, when we referred him to the periodontist and we decided both together with the periodontist, let's give these teeth a chance. Let's see what the patient can, if he's motivated enough to keep these teeth healthy. We put him through SRPs. They did some, some deep open flat periodontal, scaling and root planing. But the patient would come 6, 8 months later, suppuration, plaque everywhere. It was really, really hard for him to maintain. So he understood finally that yes, the upper teeth needed to go. We could not keep them in his mouth. We would need to consider maybe implants or maybe a denture. And this is one thing that I want you to understand. You have a patient that has active periodontal disease that he's not able to control. The question always, for me, the question is always, is it ideal for me to go ahead and transition him immediately to implants? The answer to that question is no. I don't think that that's the right thing to do. You have to make sure that you're changing the habits of this patient. This patient was a heavy smoker. He was not good friends with the dentist or the dental hygienist. So you know that you have intrinsic issues. You have personal issues, some habits that he's had that for his lifetime, that at this point he's not willing or able to change easily. And if you just go ahead and place the implants and restore this case with implants and an overdenture or a hybrid prosthesis, you may end up in a couple of years losing the implants just as quick or fast or as bad as when he had his teeth and ended up losing his teeth. So again, there's so many things that we have to think about when we are considering these cases and when we're analyzing each and every one of these cases, that they become overwhelmed. They can overwhelm you, and that's the reason why having a structured algorithm helps so much. But for now, two situations where you cannot save teeth is advanced structural damage and advanced periodontal disease or advanced periodontal damage. Now, there's three more additional contributing reasons that we need to consider. And the first one is the number of remaining teeth. Now, this is critical because, again, if you have a good number, I would say 4 or more teeth that are biologically stable or that you can restore, well, hey, that's something to consider. And I'm going to share with you a couple of examples of that. Distribution of remaining teeth. That's another key element. I mean, what happens if you have, I don't know, 4 or 6 teeth only on one side of the arch and none on the other side? Would those teeth not being bilateral, not having the right location in the mouth, would that be something that you can use? Can you probably use some implants on the other side and try to put some removable prosthesis or fixed prosthesis? Well, yeah, the answer to that question is yes. But then you have that third contributing reason, which is the aesthetic challenge that keeping any of these remaining teeth may pose. Now, let me give you a good example of this. You have a patient that has, let's say, 6 remaining teeth on just one side of the maxillary arch. So let's say that they have 3, 4, 5, 3, 4, 5, 6, 7, and 8. Now he's missing all the way from 9 to 14. And this patient has a high smile line, which means every time this patient smiles, you're going to see, if you place some implants on the left side, you're going to see that divisory line between the natural central incisor and the implant supported or retained indirect ceramic restoration on tooth number 9 all the way to 14. Can you make this aesthetically pleasing? Would you need to consider maybe doing crowns on all the other teeth? But still, is that high smile? Is there any defect on that area, on the bony area of the edentulous site? All these things need to be considered, because if the answer to those questions is yes, meaning that there is bone loss, there is a high smile line, there is some aesthetic challenge that I'm going to be confronted with, then maybe the best thing for you is to remove the remaining teeth and just go ahead and give this patient either a hybrid or an overdenture, depending on the financial situation of the patient. So these are things that you need to consider, even if teeth are not, structurally damaged or periodontally damaged. So again, those are three very important things, which is the number of remaining teeth, the distribution of the teeth, and the aesthetic challenges that they may pose. So all these things, when we're talking about aesthetic dentistry, we're talking about this. We're talking about high smile line. We're talking about low or medium smile line. We're talking about zenith. We're talking about gingival architecture. These are all things that become extremely important in patients with a high smile line and missing teeth, where you're trying to combine, fixed prosthodontics with implant dentistry and try to make this work from an aesthetic standpoint. So when you look at this, you understand now how difficult this can be, because how many patients do we have that sit on our chair that have high smile lines and bone loss and defective or defective gingival architecture? So this is definitely something that we have to think about. So again, here is a good chart. This is all directly from Dr. Mitrani's from Dr. Mitrani's article, and I don't want to take any I don't want to take, this is his paper, this is his work. All I'm doing is just sharing this information with you. And what I want you to think, and again, let's think about this together. The number of teeth, and I'm going to read directly from this article. If there are 4 or more structurally and biological sound teeth in the arch, the benefit of retaining them needs to be carefully evaluated and considered. Again, and I'll show you an example of this. Distribution, the most important thing, is the strategic position within the arch that can make an argument for keeping them. So this is also important. Where are they located? Can I use them from a strategic standpoint? And again, finally, the aesthetic challenge, the smile line. How much are they showing? Is there any gingival discrepancy or gingival or bony architecture defects that are going to be viewed or seen every time this patient smiles? So this is something that I also need to consider. And again, I'm going to give you a good example following this slide, just to kind of get into the mode of the clinical aspect of terminal dentition and the clinical aspect of how I go about this algorithm. So this is a really young patient that I had in my practice some years back. He was around 25 to 28 years old. Uh, the patient had, many personal family issues. Um, and this is how he presented to the clinic. He had lost already all his maxillary teeth. He was wearing no denture. So, and he had, very large, I would say, broken down teeth, severely broken down teeth in the mandibular arch. You can see number 20, number 21, number 28 and 29, and also, number 26 and 27. Now, 26 and 27, when I'm thinking about, okay, this is a young patient, I know that he hasn't been able to take care of his mouth for whatever reason. And it's probably going to be a challenge for me to motivate him to keep and save, these teeth. But at the same time, he was financially really, his finances were not the best. So when you consider that, if I extract all these teeth and give him a lower denture at this young age, I know that, by 40, he's going to have extreme resorption of that mandibular ridge. And now that denture is going to be dancing in the patient's mouth, making it very, very hard for him to chew, to eat, to, just to have a regular, normal life. So the only thing that I would consider at this point, and this is what I would do right now, is okay, if I need to extract these teeth, I will extract these teeth and I will place a couple of implants. But then a couple of implants, we're talking now about, 15 to 1,800, sometimes $2,000 per implant, depending on the location in the country, depending on the practice and the specialty of the provider. Now this patient is $4,000 into implants, maybe some bone graft, and now a more expensive denture, an over denture, because now we need to to connect these implants to the denture with some type of attachments. So now we're just increasing, the cost of treatment for this patient. And all these things need to be considered. So in my mind, what would have been the easiest thing for this patient? He had 4 or more teeth, which is in that algorithm, that were salvageable, that I knew that I can restore. So I could keep from canine to canine because I knew 26 and 27 were completely restorable with composite. I also knew that I needed to extract both, of all 4 premolars because they were structurally very damaged. And it would have been, a huge challenge, financial challenge for the patient to try to save those teeth. But by keeping these teeth that were also strategically located, you can see that from canine to canine, they were strategically located so that if I were able to restore 26 and 27, I can give this patient a partial. Just a partial with 2 clasps on 20, on both canines, mandibular canines. So that's what I want you to think about, because as long as I can keep these teeth, the longer I keep them, the longer that bone is going to be available. The longer that I transition that patient, I give that patient a break from being partially a dentulous to being completely a dentulous. Yes, it may be that he never gets completely motivated and that he will lose all these mandibular incisors. But there's also the chance where I can motivate this patient. I can help him clean, maintain these teeth for the rest of his life. I can also do that. I know that that's a possibility. And if I'm able to do that, I have not made this patient a completely a dentulous, which is going to be another challenge in the near future if his finances never change, which is also a possibility. So please think about all these things when you're dealing with young patients. So in this particular case, I was able to extract all 4 premolars and then go ahead and restore the lateral incisor and the canines. I restored all these anterior teeth wherever they had decay at that time. I don't remember at this point exactly where the restorations were, but I restored from canine to canine, make sure that there was no decay left on these teeth. And now I was ready to do an upper denture and a lower partial denture, just basic prosthodontic, removable prosthodontic dentistry. But at the same time, I know that I've served this patient very, very well. And if financially he could have afforded, maybe 2 implants, one distal to each of the canines, I would probably have been, able to eliminate, the clasp on those teeth. But if I can't do it now, I know that I can do it in the near future if he's ready to commit to 2 implants and then cutting off those claps and just adding some locator attachments in the partial. So there's so many things that I can do in the near future for this patient just to improve, the outcome of whatever my plan was for this particular case. And here you see the day that I'm trying in the framework, and I'm going to take the impression to find there's the process basis on the saddle areas of that RPD, and you can see, very good retention, stability, and support given by all those 6 teeth that were, they were assessed correctly, they were treated correctly, and now they've been, they've been used so that I can accomplish a final prosthetic solution for this patient. So this is Mitrani's proposed algorithm. And I want to show you this algorithm because this is exactly the one that I use every time that I'm looking at my patients. When I have these difficult decisions to make, and because, whoever is out there that knows me knows that I'm a very conservative dentist. And when you have a conservative mentality, it is really hard for you to kind of say, okay, I'm going to go ahead and just remove all these teeth for this patient. But when you have evidence to support your decision making, and this is a really good way of looking at everything. And again, you're looking at the top line, you can see the structural damage, the number of teeth, and the periodontal damage. Those are the three elements that you're going to be looking into. Again, I would add to this algorithm just the finances and the age of patients. Those are 2 things that I feel that I can add to this algorithm, and I add them every time that I'm looking at my patients. I'm thinking about those 2 things just like I thought about it in the previous case that I just shared with you right now. But if you look at this chart, you can see that all 3 elements are there: the structural damage, the number, and the periodontal damage also. And I just want you to look at the tree. I want you to look at how this tree or this algorithm helps you make those decisions, because it's very simple. If you don't have any structural damage, well, why would you extract? If you don't have any periodontal damage, why would you extract? Now, if the number of teeth, I'm sorry, let me go back once. If the number of teeth is in the right distribution, and this distribution is favorable, then you maintain. Why would you extract? Right? If the number of teeth is acceptable, and from an aesthetic standpoint, they have a low smile line and there is nothing that you need to hide, so it's adequate aesthetics, why would you extract? You maintain. So it kind of guides you. You just put these arrows. It kind of guides you when you're looking at your cases, when you're looking at your photos. And again, once you get used to this algorithm, you don't even need the chart anymore. All you need to do is just think about the steps and think about the process. But I'm going to walk you through this chart with a clinical example. So let's talk about how to apply this algorithm clinically. So let me start with this case. So again, this is one of my patients, a very nice, I would say, not elderly, but older adult. She was probably in her 60s, 65. I remember her vividly because she came to me right before she was going to retire. She still had dental insurance and she wanted to take advantage of the dental insurance that she currently had before she retired. So that's how she presented to me. And again, these patients, she literally came to me saying, I know that my teeth are not the best and I need them to have them extracted and just, get 2 dentures. And when you think about 2 dentures in an older adult patient, and you already have some resorption on that lower ridge, and you know how difficult it is to keep a lower denture in the patient's mouth without any implants, without any aids, you know that this is going to be a challenge. And the patient, right or wrong, the patient had these teeth with some partials that were not functioning well, but she was wearing them. That's what she came to the office with. So she was wearing them. The vertical dimension was very decent with them, even though they were not functioning well. But at least there was something that I can use out of those partials. And what I used was the vertical dimension in order for me to treatment plan, do my assessment, decided what teeth needed to be extracted, and go about designing my prosthetic rehabilitation for this patient. But before we go into that part of this case, let's go through the algorithm. Let's go through Dr. Mitrani's algorithm. So first, let's look at the number of teeth. Let's look at the distribution of the remaining teeth. And then let's look at the aesthetic challenge that keeping any remaining teeth may pose. Okay, so let's look at the maxillary arch. And which are the remaining teeth? So structural damage we have on tooth 4, 5, 6, and 11. So right there, then we know that all those red arrows are going to be teeth that need to be extracted. Okay, so from a periodontal standpoint, these teeth were not, they did not have mobility. They had some bleeding upon probing, yes, but they didn't have any hypermobility. So from a periodontal standpoint, there was no reason for me to say I need to extract these teeth. But from a structural standpoint, I knew that I needed to extract 4 of them, and now I'm only going to have 2 remaining teeth on one side of the arch. So with 2 remaining teeth on one side of the arch, there's nothing I can do for this patient to bilaterally stabilize any prosthesis in a good way. Again, I'm also thinking on the finances of the patient. This patient, from a financial standpoint, she was not very strong. She was getting ready to retire. She wanted to keep this, she wanted to have something done so she can be healthy for the rest of her life, but she did not have, a whole bunch of money saved in the bank in order for her to put it in her mouth. So I needed to kind of, balance all that out. So in this particular case, obviously, you kind of know that this decision is already made, right? You only have 2 teeth. They're not correctly distributed. This patient, the maxillary arch, just need to be, all the teeth need to be extracted. And we know that we're going to end up either with a denture or with a hybrid, whichever prosthesis you think is best for your patient. For this particular patient, it was a complete denture. And again, I'm thinking about I'm just sharing with you that in this particular case, finances were a big issue. So she wanted something that was, good and affordable. So I got to make decisions for her that, in the near future, she doesn't have to go back and redo any of the dentistry that I'm trying to provide, or any of the care that I'm trying to provide for her. So this is the panoramic x-ray. And for now, I just want you to look at the upper teeth. You can see the decay on this premolar, the decay on the cervical aspect of both of the premolars, fractured canines and premolars. So again, just teeth that were not really good for me to restore. So I go into this chart and I know that I have structural damage on teeth 4, 5, and 6. So right now I know that these teeth need to be extracted. Now let's look at the ones that did not have structural damage, which was 12 and 13. Now for 12 and 13, they don't have any structural damage, but when I look at their location, their distribution, the distribution was unfavorable. They were only on one side of the arch. They were not bilaterally located. So at this point, I know that these teeth are not going to be favorable for my outcome. I'm going to decide to extract those teeth. And now, when I show this to the patient, when I explain them this exactly the same way that I'm sharing with you, it's easy for them to understand, why do I need these teeth extracted? How come I'm not able to keep them? And then I tell them, hey, you know what? In the event that these will become decayed again and you will have other issues with these teeth, or they move or whatever, well, whatever we did and you lose those teeth, we're going to have to repair or redo whatever we're planning right now. So it is in your best interest, and this is exactly the way I say it, is in your best interest for me to remove these teeth because they're not in a favorable position, and go ahead and just look at this case for a full maxillary rehabilitation, either with a denture, an overdenture, or a hybrid, whichever way you want to go. Now, again, yeah, there were, tooth 12 and 13, they were not periodontally damaged, but they were not distributed in the correct way. So we know that these teeth need to be extracted. From an aesthetic standpoint, she's got all this edentulous area. She had a medium to low smile line. So for her, really, it wasn't anything to consider. My consideration was not based on aesthetics. My consideration for extraction was based on the number and location of these teeth, that they were in an unfavorable distribution. So again, you can see here the photos. In the middle photo, she has her partial, the current partial, upper and lower, in her mouth. And this is her smile. Obviously, when you have patients that don't like their teeth, they just don't show a lot of their teeth. But when she smiled, that lip went up. I would say maybe to the gingival margin, maybe covering the gingival margin of 8 and 9. So, I would say an average smile line for this patient. It wouldn't be considered a high one. But with the same token, you can see that when I removed the partials, both upper and lower, her vertical dimension was not able to be maintained, though the remaining teeth were not in contact. So again, you can see the extrusion of the premolar on the right side of the patient, on the left side of the screen. The plane of occlusion was going to be affected by that tooth. And again, you got to think about root canal. You got to think about post and core, or maybe just a core and a crown, or whatever type of restoration for a single tooth. I mean, it's a lot of investment for a tooth that probably is not going to provide us a lot of biomechanics in order for us to restore this case using 2 or 3 teeth in her mouth. So now let's look at the mandibular arch. And in the mandibular arch, there was a little bit of a different scenario. Okay, yes, there was some structural damage on tooth number 20. That tooth needed to be extracted, and we can all agree on that. But then look at the remaining teeth. Look at the remaining teeth, 21, 22, 27, 28, and 29. All these teeth are structurally sound. They had some attachment loss with no mobility. She did have some plaque. You can see some calculus around those roots. So she wasn't doing a great job cleaning them, but they were not mobile. They were flared slightly buccally, but that's, they were stable. And these canines were holding on to that partial, the existing partial. So I knew that I was going to be able to do the same thing for her. Just try to maintain those 5 teeth and try to give her a new partial with a similar design of the one that she was already used to using. That would help me maintain that same vertical dimension that she currently have, which she was comfortable with, and from an aesthetic standpoint worked out very well for me and her. So all I have to do now is just motivate her, help her understand the importance of maintaining these teeth in her mouth, because this is better than any implant. These teeth will be in her mouth to the day that she goes to the grave if she takes care of them. This is better than any other option in my mind, because I do like saving teeth, and these teeth in my mind and in my eyes are 100% salvageable. I know I can save these teeth. I know I can use them to restore this case. So that's exactly what we did. So you can see from a periodontal standpoint, you can see the amount of bone around these teeth, a little bit of bone loss on the lower left side, but nothing, again, nothing that created any mobility, any bleeding, no probing there. She actually had recession. So it was, it was easier to manage the case from a periodontal standpoint. I decided to remove those amalgams, remove any cavities that she had there, any decay, and just go ahead and restore those with composite, create my rest areas, and just go ahead and just, traditional removable prosthodontics for this patient. So again, structural damage on tooth number 20. Yes, so that tooth needed to be extracted. We had teeth number 21, 22, 27, 28, and 29. They had no structural damage, and they had a favorable distribution. So again, I knew that these teeth could be saved. They could be maintained, and the actual algorithm is helping me look at that, and and I know that I can accomplish that. So I decided on the lower arch to be more conservative. So for the maxillary arch, I'm going to extract all the teeth. For the lower arch, I'm going to save 5 of the 6 6 teeth that she had. One that was broken down to the root that we decided to extract, but the other 5 we were going to maintain. And with those teeth, we were going to decide and restore this case. So now let's talk about how to go about the conditioning phase of this case. And we're going to go using the same clinical example. I just want to walk you through this case, just the same clinical example. You can see on the photos here, the left-hand side, the upper arch with the RPD. You can see that the missing teeth, those were the teeth where this partial was really only being kept in place by the clasp on one of the premolars. The other premolar was fractured. The canines were fractured. So this partial, it was holding on. You can see that on the middle photo, that vertical dimension is an acceptable vertical dimension. And I was going to use the same vertical dimension in order for me to accomplish, use some wax rims so that I can get final impressions and send them to the lab to get an immediate denture done, so that the day of extractions of the maxillary arch, I would be able to deliver that maxillary denture immediately, so that the patient can go home and function with something in her mouth, from an aesthetic standpoint and from a functional standpoint. For the lower arch, we did all the extractions the same day. We just needed to extract one tooth, so we didn't do any interim, prostheses there. This prosthesis was working kind of okay. We just one tooth missing there, so we were able to just remove that tooth and maintain the patient with the same partial. So here is the photo the day of surgery. You can see the upper arch. We were able to remove all the teeth in a very conservative way. And then, we place some sutures, because I just want to make sure that when I reline my denture, everything is nice and closed. I don't get anything in those sockets. You're still going to get a little bit of that material in them, but a lot less by having the sutures in place. So you can see now on the right-hand side, the dentures in place, the immediate dentures in place at the same vertical dimension that the patient had with her removable prosthesis, maxillary removal prosthesis that she presented with in her practice. So we also extracted the tooth number 20 on the mandibular arch, but she was just using her regular partial. We had completed that inner immediate denture using the partial on the lower in our cast, so that the lab can go ahead and set the teeth to occlusion with that partial denture, mandibular partial denture in place. And again, I always say this: mainly for the younger dentists, when you extract teeth, if you're gentle with the tissue and you're suturing everything and everything is managed correctly, you can see 12 days later, this looks like it's healing really, really nice. We can go ahead and now remove those sutures. 10 to 15 days is the time that I wait. I remove this. I always like to follow up on patients. I know that these sutures can resolve on their own, but I just like following up on them, just making sure that I see them, that I take a photo of the arch, just making sure that everything is going the way that I have planned. And then on the right hand side, you can see the 1.5, 1.5 month post-op visit of that maxillary edentulous arch with the immediate denture and a soft reline in place. So again, this is just how this is how patients evolve. So now that we've completed the upper arch, now let's go ahead and talk about how to rehabilitate, how to go through the rehabilitation phase. So we have now completed that preparation phase where we have removed the teeth, eliminated all the infections, all the issues that the patient have, give her interim prosthesis, and then try to get her as stable as possible. Once she's stable, and I would say 2 to 3 months down the road, maybe sometimes a little bit more, I normally like waiting 6 months after full mouth extractions to try to get into my final prosthodontic impressions. And this is what I'm going to share with you now. I get to that phase where I'm now going to start rehabilitating this case. And I have a full webinar on complete dentures on my YouTube channel that you can view. I like doing, and you will see there that I like using process basis and how I go about these impressions. So, but I'm not going to go into the details in this webinar. But again, if you want to know more about the way that I do that, or the way that I handle that, or all the theories and concepts that are around those final impressions, please go ahead and visit our YouTube channel and access that webinar. It's a complete denture webinar that we have in our YouTube channel. But for now, what we need to do is that we need to make sure that we get maxillary and mandibular final impressions. Obviously, we have to prep all the rest seats and all our guide planes on those mandibular teeth, and then make our final impressions. What you're seeing here in the photo, and I'm going to walk you through the impression of the maxillary arches very quickly, but what you're seeing here in the photo is a process base on the left-hand side. So this is obtained after my final impression. This is the actual definitive base that I'm going to use for a second flask when I go ahead and set the teeth. And on the right-hand side, you're seeing my completed framework with 2 custom trays on the saddle areas, because I like doing a split cast technique from when I have bilateral saddle areas or bilateral edentulous areas. So I'm going to do a second final impression of those saddle areas only, so that the extensions of my dentures are where the saddle areas are where they need to be, of my RPD are where they need to be. So I have really good support and stability coming from those saddle areas. So again, that's why you see that framework with those 2 acrylic trays that were placed on the saddle areas for me to complete that impression. I'm going to show you what that impression will look like. But just to go quickly through my maxillary impression, I use a custom tray. I normally fabricate these trays myself. I go ahead, I either use compound or I boulder mold with PVS. If you ask me, I like the old way of doing things, because in my hands, it works so well. I love using compound, and I use it 9 out of 10 times. This is 1 out of 10 times that I decided to use the PVS, and I still make this decision for some cases. But again, this is, it's just your preference. Whichever works best in your hands, that's the way that you should go. And then on the right hand side, the completed final impression with the wash impression using a light body PVS. And again, I'm also now using a Thompson stick. I go ahead and draw my posterior dam limit or area, and then I put back that impression in the mouth so that I can get it on the impression. So when we pour the cast, we have that marked area, and the lab can go ahead and do my post dam design exactly where it needs to go. So this is the saddle area impression with the actual framework. As you can see, I've used compound for this. So I border molded with compound just to make sure that I get the right extensions. And then I go ahead and do a wash impression with a light body PVS. So this, I send it back to a lab. They will do a split cast technique. They will pour this, only the saddle areas on that split cast, and that will be now our working cast, so that we can go ahead and start adding some teeth. So then again, we take our vertical dimension of occlusion. In this particular case, it was fairly easy because we were happy with the vertical dimension of occlusion that the patient had. We had taken some photos of the patient's smile with the with the immediate denture, so that the lab can have an idea exactly what they had given us and what improvements we wanted from an aesthetic standpoint. But we were happy with the vertical dimension. We were able to just go ahead and obtain it directly in the mouth using these wax rims right here. Design the middle line, mount the cast, send it back to the lab, and now you can see we were just making sure that the vertical dimension was right where we wanted it. So we had the immediate denture, we were measuring with the immediate denture, then we put the wax trim, we measure again, we had the patient swallow, we look at the lip support. So we're looking at every little thing that you better than I know exactly what these steps are and why you're taking these steps. But again, there's nothing different here. All I'm trying to share with you is, after that decision making a tree of extracting or keeping teeth, just the process after that is just the regular prosthodontic process, whichever way you like doing it. There's so many ways today that you can do this, but this is just one way that you can do them. And you can see now we send it back to the lab. They were able to set some teeth on these process bases. These are the final process bases, both on the RPD as on the maxillary denture. So they're adding the wax to these final bases, and now all they have to do is just a second flask. We try this wax in, we make sure that phonetics is okay, we make sure that aesthetics is okay, and then we deliver the denture. And I just want to share with you this video just to show you, following these steps. We're asking the patient to remove her upper denture. She can't remove it. That's how much suction we were able to accomplish using these techniques. And that's why I encourage you to watch our video on complete dentures, because we share with you exactly everything you need to know about the impression, and how to communicate with the lab to have a process base. And this is the reason why I like that technique, because at least in my hands, the way that I do these dentures, I mean, it's just every single patient is exactly the same phenomenon. It is so hard for them to remove these dentures, if at all, if it's even possible for them to remove these dentures, because of the suction and the adaptation of the intaglio to the actual remaining ridge. And another thing that I like doing is just following up on my patients. This is a 2-year follow-up of this same patient. Look at that maxillary ridge. Look at how nice and beautifully it ended up healing. Everything is nice and pink. You don't see any pressure areas. You don't see any redness anywhere. This is the patient coming for me to see her for a follow-up. Just remove the denture. Let me take a photo of that ridge. And this is what you see. Now look at the lower arch. You can see that there's a little bit of calculus on one of the canines, on the lower left canine, but the right side, I'm sorry, the right side has a little bit of plaque. The left side looks much better. There's a kind of like a cavity going on in the premolar that we needed to restore. Just following up, just to make sure that, hey, our patients are staying healthy. If we need to do something, let's go ahead and do it early on. Let's not allow this to break down, because if it breaks down, we're going to have an issue. And I apologize, the photo on the right hand side is flipped. I needed to flip it. It's not flipped correctly. So the teeth that you're seeing on the left hand side of the screen, they really belong on the right side. So that's number 21 and 22 that you're seeing on the left side. That's where we extracted number 20. So again, just follow up, just making sure that we're looking at little things, at the little details. And if there's any intervention needed from our side, we know that we're going to do early intervention. And finally, I'm going to share with you one more case, because yes, do we have cases where we extract all the teeth and we place implants? We do, but we still follow the same tree. And this is just another patient. If you look at the evaluation of this case, you can see that he's got this tooth number 4, 5 is missing. 4, you can see the periodontal ligament, the thickening of the periodontal ligament. That tooth had a mobility of maybe 1.5 to 2. Look at the broken down canine. Look at the failing root canal on that lateral incisor, huge core on the lateral incisor, decayed margin on tooth number 9, the tooth number 13 and 14. 13, very, very little small root, mobile tooth, and tooth number 14 was fairly stable, but with a very very conservative, I would say, root canal system. And again, now you're looking at about, okay, how many teeth am I going to be able to save here? Maybe 2 or 3 teeth on one side. Or so from a number standpoint and from a location standpoint, there was really no reason why I would save any of the maxillary teeth for this patient. So it's not that I'm making an easy decision. I'm making a decision following an algorithm, and an algorithm that makes clinical sense. Now we go to the lower arch, kind of like the same situation. Oh, I forgot to mention that tooth number 14 had a furcation involvement, just like tooth number 30 also had a furcation involvement. So again, just looking at the periodontal aspect, the breaking down of the teeth, cavities, just structural damage on the teeth, and and think about on this particular patient, how much money. And I knew that this patient, when I was talking to him, he actually went to my practice. He went to the office with his wife, and when I asked him, what is it that he wanted me to see and why was he here, what was his chief complaint, he said that he had no complaint, but that his wife didn't like his teeth. So right there, then I'm getting the sense of a patient that has very little value of what's left in his mouth, very little value of the situation that these things are in his mouth. So when you think about that, well, you think about these patients. Okay, how much value are they going to add? Are they going to have if you put them through a really big and rigorous full rehabilitation case when you're going to do clinical crown lengthening, root canals, crown and bridge here and there, post and cores, just going through that nightmare financially and from a number of appointment standpoint. This is not a patient, this is not a motivated patient enough to go through that process. So again, there's so many things that you got to look into, and this is just to make your remaining teeth assessment easier. And for me, this case was fairly straightforward. He had structural damage on the upper, structural damage on the lower. He had no number of teeth that were symmetrical, that would give me a favorable distribution. I'm going to extract and extract. That was the case for this patient. Now, this patient, what was the difference between this patient and the previous patient that I shared with you? The financial aspect. This patient was willing to put some money in order for him to have some implants in the lower arch to help him maintain that mandibular denture. And I told him that would be in his best interest because he did have some remaining teeth. There was bone for me to place the implants and to keep, to add to that retention, support, and stability for that denture. So, he immediately understood the benefit of that, and that's the way we went. So this is the upper arch. These were the remaining teeth that we decided to extract based out of that algorithm. And you can see after the extractions, again, I always like just placing a cross suture, a simple suture on each of these extraction sites, so that when I deliver that immediate denture and I reline it, that's just me. You don't have to do it that way, but that's why you see that photo there. And this is the lower arch. Again, you can see the breakdown, the periodontal breakdown, the foci involvement, crown fractures, missing teeth. Just a lot of dentistry would have been needed for this patient. And the prognosis of whatever we did for him was going to be very, very low. So extracting the teeth was not going to be that difficult because they were already periodontally involved. They had some kind of mobility. So I extract them all fairly easy without no damage to the bony structures. I reduce some of the bone just to get a flat area where I can go ahead and place both of my implants. This is all done during the same appointment. You can see that both implants have been placed. Both healing caps have been also placed, screwed into the implants. I suture that in, and then I just allow this to heal. So you can see now this is probably, I would say, 30 days or maybe 45 days after both maxillary and mandibular extractions. You can see how nice the tissue is healing around the implants and also healing around the sites, the alveolar ridge on the maxillary arch. We are now just waiting for this patient to, give him 6 months final impressions and go about restoring this case completely. And that's what we did. We waited for the time. We waited for 6 months. We went ahead and we gave him an upper complete denture and a lower mandibular overdenture. And I want you to watch this video because, again, for me, this is crucial. Look at how much force he needs to apply for both upper and lower in order for him to remove those dentures. So I know that this patient is very, very happy. From an aesthetic standpoint, we were able to solve all the aesthetic issues and concerns that his wife had because he had no concerns. But at the same time, at the end, we became really good friends with this patient. He really appreciated. Okay, he understood. He now was able to see the difference between the problems that he was having before with every day was either one tooth or a crown that broke or fractured and a tooth needed to be extracted, and he would go back home. So it was a never-ending story compared to now. Now he's got one upper and one lower denture. He's happy from an aesthetic standpoint. They function very well. He's able to eat a lot better. They're stable. They're retentive. So everything that we were looking for this patient is right there. And I know that this is my last slide. And I really want to thank everybody that was here today in the morning with us during this presentation.